It's so heartening to see so many people already here. So we'll get started for the first session for today. It's my distinct honor to share with the co-moderator, Maher Karakas from Hamburg, Germany. And we have a very distinguished panel with us today. I'll introduce them if you raise your hand, because everyone would not know you and not sitting in any particular order. Benjamin Hibbert is an interventional cardiologist from Mayo, Rochester. Tarek Helemi is the Chief of Division of Cardiology, Co-Director of the Heart and Vascular Institute from LSU Shreveport Medicine. Steve Hollenberg, Professor of Cardiology from Emory Healthcare. Navin Kapur, Professor of Medicine, Executive Director of the Cardiovascular Center for Research and Innovation and Executive Director of the Cardiogenic Shock Working Group. Alexander Lamsky, Professor of Medicine, Yale School of Medicine. She's Director at Yale Cardiovascular Research Center and Board of Trustees of SCAI and Editor-in-Chief of the Journal of the Society of Cardiovascular Angiography and Interventions. And Stevens Drakos is a Professor of Cardiology and Physiology, Medical Director of the MCS and Heart Program, and Co-Director of the Heart Failure Transplant Section at University of Utah. Welcome, gentlemen, and thank you. And it's now my distinct pleasure to invite our first speaker, Dr. Navin Kapur. Is very well known in the field of cardiogenic shock and is heading the cardiovascular shock group. Navin?
Great. Good morning. Thanks, everybody, for joining us 8 a.m. Saturday morning. Where else would you want to be? But here, because of all the excitement. It's my first time at Houston Shock, so thanks for the invitations, and I'm glad I could make it, Marwan. I know you're going to kill me if I did not show up this time. But I'm excited to talk to you this morning about VA ECMO and cardiogenic shock. I'm not one to say, I told you so. So this title was given to me. It's not my choice to say I knew it, because the first thing I'll say is I don't know much. Especially as it relates to VA ECMO. If you can advance the slides. It's not clicking. Can you advance the slide?
You can do it. It's the arrow.
Yeah, it's not, there we go. Yeah, it's not clicking for me, bud. You're gonna have to reset my clock. So you can stare at my disclosures until I can get a clicker that works. And should I point it somewhere specific? It's like my remote in the house. Okay. Nope. Nope. Okay. All right. You're going to have to give me a minute back. So I think it's pretty clear to everybody who works in the ECMO space that there are a number of advantages and disadvantages of VA ECMO. VA ECMO can provide high flow, restore systemic oxygenation. It can be rapidly deployed in the right environment, and it can be used in cardiac arrest and with biventricular failure. There's also a lot of disadvantages of VA ECMO, multi-organ pressure overload, systemic hyperoxemia, direct myocardial injury, bleeding, limb ischemia, requiring specialized training, et cetera. And right now, it's not really designed for non-surgical deployment. So I think these are some of the challenges of VA ECMO in terms of making it a uniform approach. Next slide. This clicker's not working, but. So for ECMO and cardiogenic shock trials, the devil's in the data. And so these are the 4 major trials for cardiogenic shock with use of ECMO, ECLS1, as well as ECLS shock, ECMO shock, and Euroshock. I'll just point you to the red box. This is really one of the most important exclusion criteria is cardiac arrest. So the vast majority of these trials allow patients with out-of-hospital arrest, some in cases up to 45 to 60 minutes of resuscitation, which is really a very different population than a cardiogenic shock patient without hospital arrest. So that's probably one of the most important distinctions. Next slide. So when we look at the field right now, this is the summary of all the data. Essentially, there's no data that supports VA ECMO as a first-line therapy for cardiogenic shock. It has an important role in shock management, but as first-line therapy, we don't have the data yet. And honestly, I'll say that the trials haven't been designed to test that question just yet. So I think there's an opportunity for more trial design. Next slide. So we know from the ECLS shock trial, another important routine use clinical trial is what I call them, basically that this management doesn't really reflect our clinical practice in the US. We don't routinely use VA ECMO in AMI shock. We also don't do it without an algorithm and without an exit strategy. So in the red box, you can see the survival curves start to split, favoring ECLS around day 3 to 5. And that may suggest that's the time to bridge the patient to the next therapy, LVAD or transplant. But actually in this trial, only 2 out of 400 patients actually bridged to LVAD or transplant. And that is not what we do here in the US in the majority of our cases. So interpreting this trial, I don't think it'll change our clinical practice. Next slide. So this one is an important one because how do we improve ECMO? How do we get data that suggests maybe some benefit? So the Unload ECMO trial is now enrolling in Europe. And if you look at the graph on the right, the spline curve, that time point 0 is when ECMO was initiated. So in the blue, this is when you had an unloading device inserted before VA ECMO initiation, and you see better survival. If you look to the right, you can see that there's a higher risk of mortality if you use unloading as a bailout approach after you've been on ECMO for a period of hours. So this may be an approach that's now being tested in a prospective trial, Unload ECMO. Next slide. I think next slide. We're also learning that ECMO programs need to focus on not only heart recovery, but brain recovery. And so when we look at LV recovery in the setting of persistent lung injury, what we're starting to see is that the heart can recover, but now it's ejecting deoxygenated blood to the brain. So many times, 3 to 5 days later, out of hospital arrest, you resuscitate the patient on ECMO, and if you aren't careful, you can now get beautiful heart recovery. Everyone's focused on pulsatility, but there's no brain monitoring going on, and that becomes really difficult. And if you try to use an Impella or a transvalvular pump in the setting of north-south syndrome, you could actually make the north-south syndrome worse because you're sending more deoxygenated blood up to the brain. So this is where you have to do VAV ECMO and you have to use an Impella. So this is where we need to have more innovation on resuscitate and escalate strategies. Next slide. Now, Peter Osterdahl, who I'm supposed to be debating actually, but Peter and I are too close, good friends, and a very well-respected physician scientist in the field. He designed this animal model, and I read his work and then I copy it. So without any embarrassment. But Peter is amazing at what he's done, and this is his model of north-south syndrome in the preclinical setting. So we took this model, we adopted it and implemented it in our research lab, and you can see we're looking at arterial PaO2 levels in this north-south syndrome model. If you add an Impella to VA ECMO, you actually start to see that the arterial O2 levels in the thoracic aorta go down. And so that's how you're starting to send more deoxygenated blood into the aorta when you have this north-south syndrome with Impella. Next slide. So this paper came out in 2023 from Johns Hopkins. This is looking at peripheral cannulation and cerebral asymmetry using near-infrared spectroscopy. And what they show is that if you have a greater than 8% asymmetry, that actually your risk of having an acute brain injury is up to 80% in this small cohort. So this suggests the need for more monitoring and again, a focus on heart and brain recovery in the setting of VA ECMO. And that may be what changes the tide in terms of getting more, better survival with VA ECMO in shock. Next slide. I also think there's a whole area of biology that we haven't tapped into. I think the future of a lot of the drug and device combination is going to be really the optimal trials. This is a paper we put out in Circulation this year where we looked at the heart and identified loss of a protein known as tafazin when you're on VA ECMO, independent of hemodynamic load. And if we use a drug that stabilizes cardiolipin tafazin, that metabolism, we actually get better recovery of the infarct size and myocardial function. So I think the future will be ECMO plus drug therapy, and you're going to hear more about that in the sessions this morning. Next slide. But I think it's important to recognize ECMO is no longer a surgical procedure. It's not CPS, cardiopulmonary support. It's now percutaneously delivered, mostly in non-surgical environments. On the left, ELSO data showing 83% of ECMO is percutaneous. On the right is shock working group data saying that more than 60% comes out of the OR for implementation of ECMO. Next slide. So I'll end here since I ran out of time and lost a minute, but this is probably the best algorithm I've got right now for cardiogenic shock. VA ECMO is on the algorithm. I think it's important, but it has a limited role for cardiac arrest patients and also as a backup when you're trying to escalate therapy. But how we escalate, how we optimize escalation still remains to be determined. And I think that's where there's a lot of work to do. And I think we may get to a point where we have a positive trial. But right now, I would not use VA ECMO as first-line therapy for cardiogenic shock in most settings without arrest. Thanks very much.